What this isn't a technical talk, rather a strategic talk. And what the hybrid method offers us is a way to modify our surgical strategy based on our comfort level, the team that we have helping us, and the devices we have at our disposal to basically adhere to those two, the consensus that I brought forth, the patient doing things well. Live donor liver surgery is probably a perfect example of where the hybrid can trickle throughout all our practices, in that not only does the donor have to have an excellent surgical outcome, but what we extract has to work as well. So I won't belabor technical points. Obviously there's a myriad of videos that we've seen today that will rival any of mine, but I want to talk about the strategy of this, and Dr. Apicasis's points should be taken very strictly. I won't belabor this point, but we're all involved in minimally invasive liver surgery, and we know that there's benefits to it, and no matter how you do it, we're going to do good surgery through a minimally invasive route. One thing that we do know is that as we've gotten better at doing large resections, that this has been borne out in living donation. This is a group of people that we should keep healthy, and we should try to reduce their morbidity. That's very intuitive. The way that we do it is with 2 ports and hand assist. This is on one side of the spectrum. I've seen videos showing 5 ports with an extraction incision, 3 ports with a hand assist incision, and everything in between. The point is, we all do hybrid. We just do it in our own style and our own comfort level for good safety. You can see there that with only 2 ports and a small hand assist incision that we're going to attempt a right lobectomy. I don't have to discuss the history of this. We all know who has been involved in this, and when we described this hybrid method, the main important thing about that paper showed that safety was the most important thing. Having a functional graft without increased rate of thrombosis, etc., was the most important thing. One thing we have learned, that no matter how you approach it within the hybrid spectrum, that there are advantages to the laparoscopic method. You can see here we're taking down the posterior vena cava ligament, and I argue that you'll never see a better exposure than the laparoscopic method, no matter how long you make the subcostal incision. And with the new devices here, the 5mm ligature, one of many coaptive devices, you can see it can be done effectively and safely and rapidly. So there shouldn't be a consensus on whether we use the gyrus, ligature, harmonic scalpel, interlocking clips, whatever you have. Doing it safely is all part of this spectrum. What I'll do here is kind of illustrate in our cases of the points that I want to drive home. Here, with excellent exposure, you can see that there's a large V6 that we're going to reconstruct. This isn't about how to take the vein, it's about when to take the vein, how to do it safely, and in our experience, having used all the different instruments, our comfort level using the hybrid chose this one. Here we're taking the retrohepatic veins with the ligature, and they can reliably, in many circumstances, take the retrohepatic veins without hemorrhage. We've been wrong several times, but our strategy using the hybrid method allowed us to get ourselves out of a difficult predicament, whether it's the quick stitch or interlocking clips or one of 1,000 different tricks. Again, using the hybrid and being adaptable to